So I've been charged with the task of describing the status of hepatitis C to a group of Canadians whose entire lives are devoted to hepatitis C. So this might be a little bit challenging. So in fact, there's probably only one person in the audience who this is new and may be of interest to. So Mark, we will start the talk. Okay. Starting a little bit with the epidemiology. I think we've all arrived at the number of about 300,000 cases of hepatitis C in Canada, but there still is some uncertainty about the accuracy of this. There's issues related to the population being sampled, probably underrepresents marginalized populations in prisons, so it actually could be higher than this. And currently, we don't have a national approach to determining the actual real number of cases. This is a very important graph to look, and this describes the prevalence of hepatitis C by age group. And as you can see, there's this wave of patients, currently peak in their 40s, who are getting older and older, and there's this wave of morbidity and mortality that is soon to arrive and will be with us at least for the next 20 years. Okay? Also want you to have a look at the age groups 15 to 19 and 20 to 24. This represents a population where we can really target to prevent new infections and prevent these patients from suffering a life with hepatitis C. Of course, they're probably the most challenging to engage in preventative programs and surveillance programs and treatment because they're not engaged in clinical care like patients who are older. That represents a big challenge in Canada. Who are the people living with hepatitis C in Canada? And this should be familiar to everyone. The bulk, 60%, have a history of injection drug use. 20% are immigrants. A diminishing pool of patients who were infected with hepatitis C through transfusions, and then others. One population that is critically important in Canada that isn't mentioned on this slide is the Aboriginal population. We desperately need more epi in this population, understand who they are, where they are, and not to mention all the other things about engaging them in care, getting them treated. When you look at the injection drug use population and break it down, you can see that about 2/3 are previous injection drug users. So we want to get these patients on therapy to spare them morbidity and mortality. But by treating these patients, you're actually not doing anything about new incidence cases. It's those patients who are actively participating in high-risk behaviors that lead to infection with hepatitis C. If we can figure out a way to get those patients on therapy, and I know the room is full of people that is your life and trying to figure out how to do that, that's where you'll actually take a bite out of incidence. Okay? And of course, they're the most marginalized, and they're the ones that it takes the most effort and the most resources to find success with. Okay? So how do we find these hepatitis C infected Canadians? So Mark, it isn't just a matter of breaking it into red provinces and blue provinces. We have orange provinces as well, which obviously makes hepatitis C in Canada far more complex to deal with. Okay? So baby boomer screening has come to Canada. We're all aware that the CDC several years ago recommended screening all baby boomers born from 1945 to 1965. And if you do this, you'll capture about 75% of all the cases out there. Okay? The Canadian Liver Foundation has embraced these guidelines and recommended them as well. The tail end of screening extends to 1975 to represent our own epidemic in Canada. And if you screen baby boomers, you'll get about 80% of Canadians living with hepatitis C. If you screen immigrants, then you'll probably get another 5 or 10% of patients. Okay? Again, Aboriginals haven't really been considered thoroughly in these models. PHAC and Health Canada have done some very good work with this. And we are hopeful that at some point guidelines and a statement will come which will really give us guidance in Canada about the approach to identifying cases. We know that there's about 300,000 cases out there. We also know that probably only about a third of those patients have been identified. That's clearly a very critical problem that needs to be addressed, and it starts with leadership. Okay? Thank you to the Canadian Liver Foundation for starting with that. Okay, we'll talk a little bit about the morbidity and mortality. Okay? We're all familiar with this slide, some Ontario-based work done by Jeff Kwan that identified hepatitis C as being amongst the top 5 or 6 infectious diseases in producing morbidity and mortality in Ontario, and we all accept that this is likely the case in the rest of the country. Okay? This is a now famous slide from Rob Myers. The blue line there describes the number of people living with hepatitis C, and then the red, green, another red one and blue one there, whoops, describe the wave of progression through the various stages of fibrosis. And as you can see, although the number of cases are starting to decline in Canada, the burden of issues with cirrhosis, decompensated liver disease, liver cancer are all expected to continue to increase at least for the next 2 decades. Okay? So here, looking at liver-related deaths, by 2030, expected to be about 1,200 a year. It's a 90% increase from the 2013 to 2030. Cirrhosis, that's going to increase by about 45%. Decompensated liver disease, same expected outcomes. Hepatocellular carcinoma, right now, a little over 500 per year due to hepatitis C. That's expected to triple over the next couple of decades. Okay. Now you contrast that with the number of patients currently on treatment in Canada. And these are really difficult numbers to determine. So I've sort of taken them from various sources. But from around 2006 to 2010, there was probably 8,000 patients who, per year who received interferon-based treatment. So it sounds like a big number, but it really is a drop in the bucket considering the total number of patients out there. And I won't get into all the challenges of engaging people on a course of interferon treatment. The numbers actually declined from 2010 until just recently, and 2012 was estimated that maybe 3,000 people initiated antiviral therapy. Now part of that was because people were waiting for the all-oral DAA regimens to become available. Okay? And we're still, in many cases, still waiting for them to become available. Okay? Some of that, I think, are that healthcare providers have moved out of the field of hepatitis C. And I see this as a real critical challenge, is to continue to train a next generation of healthcare providers in Canada so that we have the expertise out there to actually treat and increase the care. Because if we really believe, and I think we do, that these all-oral regimens will allow us a very powerful tool to treat the masses, we won't be successful unless we have healthcare providers to do that. Which brings us to antiviral funding. So Mark said it was about the virus, it's about the money. Okay. So this black hole sort of represents the nebulous state of funding for hepatitis C antiviral therapy in Canada. It's very complex, 10 provinces, 3 territories, Indian Affairs, penitentiary system. Seems like 500 insurance companies, each with 500 different policies that are unstated. So right now it is really frustrating on the ground, treating patients, trying to navigate the paperwork to obtain medications. Okay? Do commend PEI for being the first on board to fund some of these all-oral agents, and Ontario as well, who at least have finally started funding an interferon ribavirin sofosbuvir for genotype 1s and sofosbuvir and ribavirin for genotype 2s and 3s. Okay? Now, certainly, I'm not ignorant of the fact that these medications are incredibly expensive. They may be a bargain compared to previous therapies as far as price per cure, but it's the total hit on the budget that has people responsible for these things concerned. This is an interesting bit of information. Looking at the specialty drug spending and utilization in private insurance plans over the last couple of years. You can see that from 2010 to 2013, only about 1% of all the claims were for specialty drugs, and hepatitis C drugs would be considered under that. Much like some oncology drugs, some of the medications for rheumatoid arthritis, those types of medications. But although it's responsible for 1% of the claims, it's responsible for nearly a quarter of all the expense. So this is the issues with the cost of hepatitis C that private payers and provincial governments are facing in Canada aren't just for hepatitis C, it's for every disease state that you can think of where these incredible new advances in medications are arriving, and they're all extremely expensive. Okay? But you need to weigh that with the costs of not doing anything or waiting until patients have advanced stages of liver disease. And you can see as you progress from minimal fibrosis all the way to the need for a transplant, the costs exponentially increase. So clearly, your bigger bang for the buck is to treat people before they get sick. Okay? And this is talking about money, not alone the human cost and the loss of manpower in our economy. Okay? So these are some predictive models looking at the impact of actually getting treatment out to the masses, the impact on death, cirrhosis, decompensated cirrhosis, and hepatocellular carcinoma. So if we treat early enough and we're able to figure out all the logistical issues and getting the treatment out to the people that need them, we can really have a significant impact. So things don't have to be as dire in 2030 as predicted by some of these models. Okay? These medications also give us a very powerful tool to realistically talk about the eradication of hepatitis C in Canada. Okay? And right now we're fixed on the money and the logistics, but this should ultimately be our goal. There's no reason why we can't accomplish this. We certainly have the expertise in Canada to do it. Okay? So I'm going to talk a little bit about the models of healthcare delivery and what we really need to do if we're going to accomplish this. We're aware of this. I couldn't find a Canadian equivalent slide, but this basically reminds us about the cascade of hepatitis C care and how out of the total group of people living with hepatitis C, it's only a small proportion who've actually been tested and identified, and by the time you get down to treatment and successful treatment, you're only curing a small proportion of patients. All these new DAAs give us a very powerful tool to actually get greater success. Okay? But there's challenges. It's maintaining and increasing the level of expertise out there. Okay? And expertise not just in specialty trained individuals, but family physicians, nurses. We need to take advantage of all those populations. A special comment is for the non-hepatologists in the crowd. Given the fact that we're dealing with a population with more and more advanced liver disease, if we're going to be managing hepatitis C, you need to know your liver disease rock solid as well. Okay? You can't just focus on hepatitis C and ignore all the other stuff like screening for liver cancer, ruling out other viral and non-viral causes of liver disease. Okay? Capacity. We have very well-equipped clinics in Canada, but they're generally in large urban centers, generally in hospital-based centers. We need to have this clinical capacity throughout the country, which is a tough thing considering how big the country is and how spread out the population is. We need to be able to assess fibrosis. This is clear that the priority for treatment and the funding is intertwined with the level of fibrosis. And currently FibroScans are not paid for and they're not reimbursed. We need to address that if we hope to have that technology available to screen patients. We also need the laboratory expertise. Again, laboratory expertise is centralized. Try to get the blood tests done that you need for a fibro test in rural Ontario, an hour outside of Ottawa. It's a nightmare. So we need to do more to build up that level of expertise. Adherence is critical, and reaching marginalized populations. Okay? Again, the marginalized patients are always the ones to benefit least from new advances in treatment. And it's also critically important to target these patients because you'll address not just prevalence, but also incidence. Okay? So these are not novel, okay? But telemedicine is a critically important technology or approach to engaging marginalized remote patients. It works in New Mexico. In a country like ours where so much of the population is spread in rural and in northern areas, it's critical and it certainly works. So it needs to be embraced. The hub and spoke approach, where we have centers of excellence that have strong ties with community centers, is critical for engaging these patients who just can't make it to a urban-based tertiary care hospital system. And these are ways forward. I know there's many others, and I know there's people in the crowd who spend their career trying to figure out how to do this effectively. Okay? We all have a tendency to sort of be stuck in our ways, but I'd remind you that no matter what your role is in the clinical care of hepatitis C, you're going to have to change with the times. Physicians think we're going to have to start focusing on the more complex cases, okay? And nurses, greater responsibility for treating especially pre-cirrhotic patients, bigger focus on adherence. In the old days, nurses' main focus was on trying to get people through the awful side effects. Yeah, need to change with the times. Okay, pharmacists are a critical component of the team for identifying drug-drug interactions. Okay, social workers, well, trying to figure out ways to get these medications funded with, and psychology. It's not so much getting patients through interferon neurotoxicities, it's adherence that needs to be focused on. Okay, quick word on research funding. Currently, there's about $12 million in Canada that's spent on hepatitis C. It depends what you count, what you double count, what you don't count. This is from the CIHR, by the way. The NIH, in contrast, spends about 110 to 114 million a year on hepatitis C. Okay, so thank you to the CIHR. Thank you for their vision for trying to put funding in place to establish a network for hepatitis C research. This is a great start. I think we all would agree that the level of funding needs to be increased so we can actually tackle these ongoing research questions. And I would just remind everybody that there are many, many research questions that still need to be addressed. Okay? We need to, and I've already run across it in my own grants, and I suppose other people have, that the comment that, oh, hepatitis C is a done deal. We have all these DAAs. It's simply not true. You think of any basic science, clinical science, behavioral, epi, there are multiple questions that still need to be answered, and it's critical for informing care and critical for informing how we allocate our funding. So need to protect the funds for hepatitis C. So that's it in a nutshell. The idea was to set the table for the rest of the day. We have speakers in all the tracks who are going to expand on each of these. So just to get the thoughts going, I was trying to think, is the cup half full or half empty in Canada? And I guess I remain undecided about that. Maybe by the end of the day we'll know. So thank you.